Hello everyone. So today we are going to talk about migraine, and I'm sure that some of the viewers might also be suffering from migraine. And if you do, please comment down in the section below, because I know because everyone knows it's a very common disease, and also it is an interesting topic to study. So let's begin. Okay. So first we'll be talking something about headaches. There are two types of headache, primary ones and the secondary ones. So basically primary are the non-dangerous and the secondary are the dangerous headaches. Okay, so what you need to remember is non-dangerous headaches have no underlying cause. Okay, so you need to remember that they do not have any underlying cause, while the dangerous headaches have an underlying cause. Okay, now you need to remember that under non-dangerous we have the tension type headache, the migraine, and lastly the TAC, that is trigeminal autonomic cephalgia. In this particular video I'll be talking just about the migraine. Okay, so let's start. I'll be making another video for tension type headache and trigeminal autonomic cephalgia. So let's begin with our main topic, migraine. So first we'll talk about the classification of migraine. So we have two types of migraine, the classical and the common one. Okay, so the classical one has aura, and in the common there is no aura. So 80% cases are common migraine, 20% are classical migraine. So what is an aura? Aura can be a visual aura, auditory aura, visual aura, auditory aura, then sensory aura. Okay, so what is an aura? Aura means the person sees or feels something which the other person cannot see or feel. Okay, like zigzag lines. Okay, so here I have drawn zigzag lines because you can remember that zigzag lines are the commonest aura that a patient of migraine can present with. Okay, so you need to remember it is the commonest aura. Okay, other auras are in the sensory we have tactile, I'm sorry, okay, so in sensory we can have tingling or some tinnitus like sensation on the hand. In visual we can have fortified spectra. Okay, we can have fortified spectra. Then we can also have floaters, scintillating scotomas. Okay, now you need to remember that this aura occur half an hour before the actual headache. Okay, and the headache episode lasts for 3 hours to 3 days. Okay, so this episode lasts for 3 hours to 3 days. Okay, and what is the characteristic of this headache? So this is usually unilateral frontotemporal throbbing headache associated with nausea, vomiting, photophobia. Phonophobia means the patient is afraid of loud noises and flashy lights, etc., and the patient wants to stay in a dark room. Okay, dark room which is quiet. Okay, so the patient wants to be in this, And there is classically nausea, vomiting, photophobia, phonophobia. The region is frontotemporal and the type of headache is throbbing headache. Okay, so we saw this, then we saw this, and of course this headache characteristics would be in both the without aura and with aura. Okay, but this aura would be present only in the classical migraine, which is only 20% of cases. Okay, there is general there is general thinking that okay, the patient if is having migraine, then he would be having aura, but it is not so. Okay, only 20% cases have aura. Okay, now you need to remember this criteria for migraine. Okay, so for this you need to have 5 attacks lasting for at least 4 hours to 3 days. Okay, and very important, normal neurological examination. Okay, the neurological examination that you see is normal, and then you can diagnose migraine. Okay, then you need to remember at least two of this, that is unilateral pain, throbbing pain that is aggravated by movement, and severe to moderate intensity. From this 4 points, any two of this would be should be present, plus any one of nausea, vomiting, photophobia, phonophobia. Okay, so either nausea, vomiting or photophobia, phonophobia should be present. Okay, so this is the criteria that you need to remember. Okay, now let's talk about the pathogenesis of migraine. Okay, so pathogenesis, if we talk about, then basically there is this vascular theory which says that vasoconstriction of intracerebral vessels causes aura, and vasodilation of intracerebral vessels causes the actual headache. So now you understand that for prophylaxis of migraine we use vasodilators, but for treatment of migraine we use vasoconstrictors like triptans or dihydroergotamines. Okay, so this is the pathogenesis of migraine. Now I want to talk about some triggers of migraine. So basically there are many triggers, loud sounds, flashy lights, then extra stress, then you need to remember sleep deprived or excess sleep, okay, or hunger, alcohol intake. Okay, all this can trigger this migraine. Okay, hormonal fluctuations, all this can trigger migraine. Okay, so you need to remember this. Fine, now let's move to one important question, that what is the most important pathogenic cytokine of migraine? So the answer is CGRP, that is calcitonin gene related peptide. Okay, calcitonin gene related peptide. Fine. And the center of pain for migraine is trigeminal-vascular complex. Okay. Fine. So that was about the features, the criteria, types, and the pathogenesis of migraine. Now let's talk about the management of migraine. Okay, so management of migraine in acute attack, we have three types: mild, moderate, severe. Okay, so mild attack will manage by NSAIDs. Moderate attack, moderate and severe both, we will give triptans. Okay, in triptans you need to remember rizatriptan and elatriptan are the most commonly used and most useful for this condition. Okay, because they have a maximum T half. Okay, that is why these both are used. Okay, oral. Now we have one more, that is sumatriptan and zolmitriptan, which both of which can be given nasally or orally. And you need to remember sumatriptan can be given subcutaneously in a severe attack. Okay, so if a patient is having a very severe attack and you need immediate relief, then you can give subcutaneous sumatriptan. Okay, important, remember. Now another option, if we don't want to use, or if we cannot use triptan, then another thing that we can use is ergot alkaloids. Okay, so ergot alkaloids can be used. Now you need to remember certain triptans disadvantages. Okay, so remember, triptans cannot be given in a cerebrovascular disease, like a patient of previous MI is coming to you with with migraine, then you cannot give triptans. Okay, then you can also not give triptan in a pregnant lady. Triptans are not effective in classical migraine, that is the migraine with aura. Okay, so remember, if a patient with comes to you with migraine with aura, then don't give triptan. Okay, give ergot alkaloids. Okay, and also if one triptan is not effective, you can give another triptan. Okay, and also ergot alkaloids, with ergot alkaloids there is less recurrence of headache. Okay, so these are the points that you need to remember. Fine. Now we will move on to prophylaxis of migraine. Okay, prophylaxis of migraine. So in prophylaxis of migraine, you need to remember that we can give propranolol. First line is propranolol, then TCA and topiramate, and second line is ARB, that is telmisartan, then CCB, that is valproate, and venlafaxine, which is a SNRI antidepressant. Okay, so this was about the prophylaxis of migraine. Okay, then there is this newer treatment that you need to remember, that erinumab is a monoclonal antibody which is approved against CGRP. Okay, so this is a new treatment that you need to remember. Okay, and lastly we have to remember that the migraine can have autonomic symptoms. Okay, autonomic symptoms like the what we say, tears, congestion in the eye, rhinorrhea, etc. Okay, so don't confuse the migraine with sinus headache. Okay, fine.